Yes, now start.
Here we have a 30-year-old lady, a mother of 4 children, 36-year-old. She presented to us with this Chiari 1 malformation and syringomelia, and she has the typical symptoms. As we can see here, the cerebellar tonsils reach below the level of C1, that's to say to the almost the middle part of the C2 body, and the cisterna magna almost full, and the premedullary cisterna does not show up here on this MRI. This patient underwent surgery in August 2008, and after the operation she did not improve, but then a control MRI was done where the tonsils and the syringomelia were exactly the same. Nothing was done intradural, but there is a little CSF leak here in the suboccipital area. This patient kept on deteriorating slowly, and this is a control MRI on the 10th of September 2008, where we can see that the suboccipital collection of CSF has increased. And this patient again deteriorated slowly, and she couldn't do anything at home. And then a control MRI was done on the 18th of May this year, where the collection of the CSF has increased very markedly. And there are some hypo-intense things here seen in the suboccipital area. Anyhow, a few days later this patient deteriorated, and she developed severe headache and vomiting and papilledema, signs of increased intracranial pressure. An MRI was done where we can see this acute hydrocephalus with very markedly dilated ventricular system, infra and supratentorial, with transudation of CSF through the ependyma, and the sagittal MRI shows even turbulence of CSF in the 4th ventricle, and with very markedly increased syringomelia. The syringomelia has increased very markedly, and even became involving the medulla oblongata, as we can see on this MRI, very nicely demonstrated. And the collection of the CSF in the operation on the operation site is very marked. We operated upon this patient today, where we found that a dural patch lying in this space, it was not fixed, it was not stitched, nothing, lying in this very big hole, and we found a small hole in the dura through which the CSF comes. What we did a gradual decompression of the CSF, and we removed part of the lamina of C1, which wasn't completely removed. And then we opened the dura, and we found the tonsils really in the same place, and nothing was done on the tonsils. We did incomplete resection of the cerebellar tonsils, and we opened between the cerebellar tonsils, and we found an arachnoid membrane obstructing the CSF flow. And we opened until the 4th ventricle very slowly, and we decompressed the CSF very slowly, so that the ventricles became slowly decompressed and intracranial pressure reduced. We created a cisterna magna after doing incomplete resection of the cerebellar tonsils, and then we found also adhesions between the pia of the spinal medulla and the dura. We released the adhesions. We made the free flow of CSF from the 4th ventricle into the cisterna magna and into the spinal subarachnoid space. And then we took a fascia lata. We discarded the dural patch, and we took a fascia lata from the right time, and then a triangular piece, and then we sutured this, and the operation was very, very smooth. And during the whole operation, the patient did not show any changes, any abnormal changes in the ECG or in the intracranial pressure or in the pulse, blood pressure. And she recovered very smoothly today, and she will be transferred in a few minutes to her bed.
Why do you think the hydrocephalus developed now? It was not there in the post-op scan of even of May 2008. If you see there, this is the scan of May 2008. There was no hydrocephalus even now.
Yes, till May 18th.
Yes,
there was no
this is a scan of 18th May.
Yes, and I think because of this puncture, this small hole which was done in the dura, it is just above the lower pool of the tonsils. It has worked like a valve mechanism.
Ball mechanism.
Yes, the CSF flew outside the dura into the suboccipital area where we saw here a very big collection, and after that it compressed on the spinal subarachnoid space, the upper spinal subarachnoid space, and the CSF did not flow anymore. So that made the collection of the CSF into the cranial cavity, into the cranial CSF spaces, with the development of, as we saw, very big pseudomeningocele and or iatrogenic meningocele, and markedly dilated ventricular system with exudation of CSF transparent transependyma. We did not do any shunt procedure or any external drainage, because this patient, as you can see here on this MRI, till the 18th of May this year, she did not have any hydrocephalus. What we did 4 days before surgery, we aspirated about 70 cc of blood percutaneous from the suboccipital collection, and that made a good recovery of the patient. That was, I think, a key point in treating this patient. We reduced the intracranial pressure by draining or by aspirating about 70 cc's 4 days before the operation.
CSF?
Yes. That made a good recovery of the patient. The patient recovered very well, and she could eat, and she could move, and she could talk. And then we decided to do the surgery today, and now she's doing very well.
Okay, this complication occurred because there was a intradural approach of...
No, this complication occurred because the dura was not opened completely, and the tonsils were not touched at all. You see, in this case, we have to resect the tonsils, completely or incompletely. If you have enough space, you don't need to resect more. You can resect 3/4 or 4/5 of the tonsils. There are different ways. You can do a sub-pia resection using cavitron ultrasonic aspirator. We don't have this one, but you can do what you can. You can coagulate the tonsils very slowly under continuous irrigation, and this is what we did.
What about the extradural approach? There's an extradural approach. You don't touch the dura at all. Do you practice that?
No. Then you do nothing if you don't open the dura, and you do nothing if you don't open the dura. And what I do, I open the dura, I resect the tonsils, the way I did, using a continuous irrigation, and we use a bipolar under low setting to coagulate the tonsils very slowly. And in this case, we had to resect a big part of the tonsil on the right side, which was bigger than on the left side. Okay, and then we had to open between the cerebellar tonsils into the fourth ventricle. And in this case, we found an arachnoid membrane obstructing the flow of CSF. And it was very there was a very small opening in that arachnoid membrane. This I found for the second time in these cases. Okay, and we ensured a free flow of CSF from the fourth ventricle into the cisterna magna and then into the spinal subarachnoid space. And then I prefer always to use a fascia lata. A small incision will not make much. This is a life-saving operation, and it's a big operation. And if you make a small incision, to me, I like to take a fascia lata than to take any artificial dural patch or liudura or whatever. I like always to take fascia lata from the same patient. Okay, and now I'm expecting her to recover completely. Now she is doing very well till now.